I click start.
Yeah, live now.
Yeah. Do you want me to record it?
It automatically will
Oh,
record.
really? Okay.
Yeah.
Okay. Yep. Okay.
So we have one attendee so far. We'll roll in.
Okay.
Here they come.
Mm-hmm.
Yeah, they're starting to roll in. So I can
Mm-hmm.
start here, another minute or so. Well, I think we can begin, Dr. Dizon. Yeah.
Yep.
Okay. Well, I'll start with a little welcome. Good evening. Welcome to the iRise and Shine Wellness Collective webinar series. My name is Jillian Lashota, and I am the founder and executive director of the iRise Above Foundation. Our organization strives for an outstanding quality of life, empowerment, and inspirational support of young women diagnosed with breast cancer. And our mission is to surround these young women with targeted, age-appropriate, and connected health and wellness resources and tools to enable them to rise above the residual effects of breast cancer, heal, and live well. This evening, I would like to welcome all of you and our guest of honor, Dr. Dizon. Dr. Dizon is a professor of medicine at Brown University and a medical oncologist with research interests in novel therapies of breast and pelvic cancers, survivorship, particularly as it pertains to sexual health for men and women with cancer, and social media. He is the director of the Breast and Pelvic Malignancies Program at Lifespan Cancer Institute and director of medical oncology at Rhode Island Hospital. Additionally, he is the chair of digital engagement for SWOG Oncology Research Network. He is the co-chief medical officer at the Global Cancer Institute and serves on the board of the Hope Foundation and Young Survival Coalition. He is a prolific author and writes columns for multiple sites, including the professional journal The Oncologist, ASCO's networking site, Connection, and for Medscape. This evening, Dr. Dizon will be speaking to us about sexual health after breast cancer, intimacy, intercourse, and everything in between. Dr. Dizon, welcome.
Thank you so much, Jillian. It's really a pleasure to be here. And I think I've been following this foundation now for a couple of years, and it's, sadly, we're all grounded, but hopefully it won't be forever. So I will be discussing sexual health after cancer, and specifically after breast cancer. I decided to give a bit of a primer, so this won't take very long, and then hopefully during this presentation, I'll answer a lot of questions that come up, but if not, I'm happy to take questions afterwards. So just to put this in perspective is that if you are having issues with your sexual health, whether that be discomfort with intercourse, or even just that ability to get aroused, realize you're not alone. This was a Livestrong survey that proves this point. It was done in over 3,000 people. Most of them were white, but most of them were also female, and over half were at least a college graduate. What's interesting is that most of these folks were young, and the prevalent cancers, as noted here, were breast, colorectal, and lung. But what they found was folks who have complaints of sexual health dysfunction constituted over 50% of the population. And what was even more striking is that most of these folks never sought help. Now, when I, call something sexual dysfunction, what oftentimes will happen is that people don't really understand what that means, and there's assumptions that sexual dysfunction really equates with trouble with intercourse, and that's not true, because sexual health is really far more than the act of intercourse. It starts with that sense of intimacy and goes into the experience of sensuality, how one views their body image, the experience of arousal and desire, climax, and then importantly, of satisfaction. So these are the multiple domains that comprise female sexual health, and all of them cannot be easily characterized into an act. So this comes into this one question, which I ask both providers as well as people living with cancer, that after a diagnosis, sexual health in women and in men is impacted similarly. When I ask this as a true or false question, I think the audience is oftentimes split, or maybe 60% false and 40% true, but a vast minority of people do believe that this is true, but in fact, it's actually false. So we oftentimes will depict male sexuality as an on and off switch, that only when the switch is on, when one is erect, does the whole experience of sexual health actually kick in. That's when a male partner wants to be closer to his partner. It's when one senses they want to hold hands because it's being driven to a goal, and that goal is penetrative intercourse. For women, it's exceptionally more complicated. All right. There is not a switch, it's more as a computer board. And when we are all healthy and when things work, you don't think about how come you are sexually aroused. You don't think about why intimacy happens to you, because it happens. And much like dominoes falling, everything makes sense. Cancer can actually interfere with each of those process steps. And all of a sudden, you're stuck with a computer where you turn it on. There might be some whirring, but the screen doesn't come on. Nothing is happening. And the experience is confusing because all of a sudden, something exceptionally natural isn't working the way it used to. And something natural all of a sudden becomes foreign. And not only is that cannot be very disappointing, it can be alarming, and it can actually cause a lot of fear. So, what should you know about sexual health after cancer? This is a model of sexual health that was developed by a gynecologist, Rosemary Basson, now, what, 20 years ago. So, what this model proposes is that the thing that wakes up a sexually dormant person is this want of something more in their life, this want of intimacy. That is what wakes up the body to understand when things, certain areas are touched. Not only is it stimulating, but you get aroused from it. This experience of arousal is the food that feeds desire. And when desire is satisfied, the entire circle propagates. Now, there is this bypass of intimacy called hunger, where the satisfaction leads to more want of stimulation, and it bypasses intimacy. So that definitely has been proposed. But for most people within oncology, this seems to speak very well to that experience before cancer. What cancer can do then is actually interfere with all of these arrows. All of a sudden, things that used to bring you stimulation aren't stimulating. The stimuli that used to lead to pelvic arousal isn't working. And so the desire is less, and certainly it's not as satisfying if things happen. Now, what's important about this model is that sexual activities, any singular activity, is not embedded in female sexual health. So women do not rely on intercourse to be satisfied. Women don't rely on self stimulation for satisfaction. This explains, and I say this during conferences, this explains why this link towards satisfaction and desire is oftentimes driven by non sexual actions like doing the dishes, or making you a nice meal, or buying you flowers. That can be as satisfying to a female person as it is to have intercourse. Now, there's another concept that is very specific to people treated for breast cancer, and it has to deal with breast specific sensuality. This is a term that was coined by my colleague Jennifer Goss, who did a convenience sample of women coming into a surgical clinic for follow up. And she just basically asked them very simple questions. Was your chest, your breast, a part of your sexuality? And she saw, regardless of what procedure that was done, 80 to 90% of women, their breasts were an erogenous zone. That led to arousal and peak desire. But after surgery, that falls by at least 10 percentage points. And for women who had a mastectomy without reconstruction, it's even worse. You're talking about an almost 30-point drop in seeing their chest as part of their experience of sexuality. Now, when you look at the two that were most alike, so breast conserving surgery and those who had mastectomy with reconstruction, she asked these groups whether or not they felt their breast or their chest wall was currently a part of their experience of sexuality. And it was the same. 40% no longer perceive their chest wall or their breast as a sexual organ. You lose that in the treatment of breast cancer. 40% will. In fact, if you just concentrate on the orange, when asked what experience is like when your treated breast, when your chest wall is now touched, there was an unpleasantness to being touched there in 1 in 5, and there was anesthesia, no sensation at all in the reconstructed breast in half, and in 30% of those who had lumpectomy, presumably who also had radiation. So we, you as women, as people treated for breast cancer, give up breast specific sensuality with the treatment of breast cancer. So if you had the experience where you can only undress in the dark, or if you don't want to go to bed naked without a camisole on, or if you won't allow your partner to touch your chest wall, this explains what you lost. And it's quite critical and important that there's a name to it because it's real. Now, how do we approach treatment for sexual health after breast cancer? It's really important to think about it in two very distinct domains. One is to talk about physical health. In this case, we're talking about caring for the vagina and the vulva as part of a regular routine of health. Then we can talk about sexual health, which really is specifically geared towards making sexual activities more pleasurable. So with vaginal health, what the other term is oftentimes genitourinary symptoms of menopause, or GSM, which for younger women can come at them like a brick being thrown through a window. It can be that dramatic. Vaginal moisturizers are the mainstay of treatment in vaginal health. The benefit of having a healthy vagina and vulva is that sexual intercourse, penetrative activities, sexual play is more comfortable. Now, realize that there are many types of vaginal moisturizers. Polycarbophil based, otherwise known as Replens, is one, but there's vitamin E, can also be considered a vaginal moisturizer. You can use natural oils, coconut, or even olive oil, but the instructions should be to apply it externally on the vulva, not internally within the vagina. Theoretically, there's a risk it could go rancid, although I've never seen it. Now, for those folks who want to stay away from chemical preparations, especially parabens, because in the laboratory, parabens can have estrogenic properties, although it's never been proven to have an estrogenic effect in humans, there are parabens-free formulations like Levina. Here is the important point, because this is not in any box. The instructions for people after cancer is to use it liberally and use it frequently. So I will tell people to use it 5 times a week, and you can also use it 1 hour before intercourse in that attempt to create a more healthy pH and healthy vaginal volt. Now, there is also some talk about vaginal laser therapy. I know this was 3 or 4 years ago. It was very popular to discuss whether or not it works. Realize there's never been a randomized trial comparing vaginal laser therapy to, say, a sham after treatment for breast cancer. So all we have are selected cases and case series. This is an example from Italy, looking at 50 women who had pain with intercourse or dyspareunia after what was deemed an oncologic menopause. And what they showed was that with CO2 laser therapy, there was an improvement in painful intercourse, which was defined by a visual analog scale. There was improvement in atrophy by the Vaginal Health Index, so very standardized measurements, and that these improvements lasted for more than 11 months in half. Now, the problem is here, there was no comparator. And that's important because the placebo effect in these studies can range between 40 and 50%. So this is a hypothesis that it could work. It's very far from being definitive evidence. There is also this warning that came out 2 years after this Italian report because the FDA was collecting reports from women suggesting that they were experiencing serious side effects, including vaginal scarring and burns. So, in the absence of good evidence and in light of the risk, this is not something I recommend. What about vaginal estrogen? A huge cause of concern for women, especially with hormone-positive breast cancers. What I'm showing you here is the American College of Obstetrics and Gynecology on their stance on vaginal estrogen. What I will also say is a similar statement has been made by the American Society of Clinical Oncology and Cancer Care Ontario, so the Canadian measures as well. Number one, non-hormonal approaches should always be tried first. Number two, if number one doesn't work, this is where vaginal estrogen therapy can play a role. Because, number three, there is no data that shows an increased risk of a recurrence after breast cancer with the use of vaginal local estrogen. And that's even true for hormone positive breast cancer. So, what about oral hormone therapy? This is a totally different thing. This sort of summarizes where we are. It is contraindicated in breast cancer, especially in hormone positive breast cancer, but not in other types of malignancy. So, if it's safe in other cancers, what makes it different with hormone positive breast cancer? This is the trial that gave us pause. It was called the Hormone Therapy After Breast Cancer Is It Safe trial, or HABITS. Now, this was an open label randomized trial of early breast cancer, 500 volunteers, most of whom were on tamoxifen, and they had hormone therapy for 2 years. Now, here's the important points in bold. You cannot give the same hormone therapy to all people. So if you have a uterus, it is not safe for you to go on unopposed estrogen because estrogen can cause hyperplasia in the uterus and predispose to uterine cancer. So you need that withdrawal period. That's where progesterone comes in. So combined hormone therapy for women with a uterus is what's used. But if you had a hysterectomy for whatever reason, you don't need combined hormone therapy and you can go on estrogen only. So that was the intervention. The comparison was just symptomatic care. Compared to no hormone therapy, there was an almost twofold increased risk of a breast cancer event. What does that mean? It means that over 5 years, there was almost a threefold increase in either a local recurrence or contralateral breast cancer. Okay. Um, but the risk seemed limited to people with hormone positive disease. And because the follow-up was too short, they did not see any impact on mortality. So the HABITS trials showed hormone therapy raises the risk of a breast cancer event. Whether or not it has an impact on mortality was not shown. This other point is also relevant for this population. The study could not answer whether or not the kind of preparation mattered because, again, the women were different. And if you go way back to something called the Women's Health Initiative study that showed there was an association of hormone replacement therapy and breast cancer, that was only seen if you use combined estrogen and progesterone hormone therapy. However, if women were able to use estrogen only, they had a reduction in the incidence of breast cancer. Okay, so it's not a straightforward and simple answer, but at the end of the day, we would prefer not to put people with breast cancer on oral hormone therapy. What about testosterone? The reason we look at it is because there's good data in multiple trials showing testosterone can improve libido, it can improve interest, and then frequency of activity as well as orgasm in three very distinct populations: in postmenopausal women, in women who have a desire disorder, which means they can go through and have an orgasm, enjoy the activity, but afterwards they don't care if they ever did it again. And they saw it had an impact on women who had surgery, or surgical removal of their uterus. So the question after breast cancer, are there benefits to outweigh the risks of androgen, uh, masculinization? So there was a randomized trial in postmenopausal women of testosterone versus placebo, and they looked at whether or not it can improve sexual desire. And these were the results: that even with a crossover at 4 weeks, they could not demonstrate an impact with testosterone compared to placebo in women treated for cancer. So based on this randomized trial, which is flawed, I don't use testosterone to help improve desire because we don't have great data that the benefits will outweigh the risks. So moving forward, how does one improve sexual comfort? Vaginal lubricants are important. So lubricants are not moisturizers. Lubricants are to be used as needed for any penetrative activities. Now, there are two types: water and silicone-based lubricants. And at least this one trial that was done in 2011 showed no preferred preparation. What I will say is that the silicone-based lubricants tend to stay slicker longer, so a person does not have to feel the need to reapply. However, it will also stain your sheets. This is a very salient point, though. I have met women who went through their lives before cancer where all they needed was saliva, and that worked great. Realize saliva is not a lubricant. What about natural oils? Can you use something like olive oil? Can you use coconut oil as a lubricant instead of something chemical? There's very little data, but like I stated before, as a moisturizer, there are concerns that using a natural oil as a lubricant could become rancid. I will point to this exceptionally small data set of 25 people where olive oil was used during intercourse. And in this group at 12 weeks, 73% felt olive oil was useful. Okay. There's very little data otherwise. So what about if you have pain with penetrative intercourse? Realize that that has multiple issues. There is at least two types. There's pain with initial penetration, where you're trying to penetrate what's called the vestibule, which is the opening to the vaginal valve. That is termed vestibular tenderness. But there's also pain with repeated thrusts or repeated um, insertions into the vagina. That is actually uh, a smooth muscle contraction that is not controllable. Okay. This is the only situation where I think you really do need to do a pelvic exam, because the findings on an exam can help influence a treatment plan. Here's one way. So this was a randomized trial that was performed at Oregon Health Sciences University by my colleague Martha Gage. She took 46 women treated for breast cancer who were having pain with penetration, 8 out of 10 pain scores. And she compared the use of a water-based lidocaine formulation, 4%, so exceptionally dilute, versus placebo. What she saw was after 1 month of use, the women on the lidocaine did much better. And in fact, when she provided this solution to all participants, 90% reported comfortable penetration, and 17 of 20 who were abstinent were able to have penetrative intercourse once more. The caveat is, if you had pain with thrust or vaginismus, this didn't help. So what can help with painful thrusts or vaginismus? This is where we rely on the vaginal dilators, and they come in many different forms. This one on the right is the one that I usually have in clinic. These are silicone lubricants, so they're flexible and a little bit softer than, say, the Syracuse dilators, which feel like candlesticks. These also have a head to it, and I'll admit, not great data that it works. And the reason why is that compliance is an issue. So because of that, many of my colleagues, as well as I, will instruct people to use this in the morning rather than at the end of the day, to incorporate this into a regimen of getting ready, because this is the time when most people have to themselves. And if you are like most women in the United States or elsewhere who are multitasking, now even taking care of children at home while they're in school, the last thing anybody wants to do at the end of the day is to lay on a floor and do vaginal exercises. So incorporating the morning might have more motivation. This is a new one on the market. This is actually remote controlled to extend lengthwise as well as girthwise, so a woman can control it. No randomized data say that this is better than the old school stuff. There are also other pills that are available to help with desire, but when someone tells me that they're not interested in sex and their desire is low, oftentimes the solutions aren't pills, because oftentimes there's something that's causing the loss of desire. Painful intercourse, body image issues, a lack of stimulation, a lack of arousal. So we can usually try to correct the other things to help bring back desire. But for women who have that sort of primary interest or arousal issues, flibanserin, bromelatonide, bupropion can all be tried. However, this is the problem. We have very little data that it works after cancer. That's important because both trials that looked at flibanserin and bromelatonide excluded people with cancer, excluded people on endocrine therapies, including anti-estrogens, and excluded people on antidepressants and anxiolytics. This is not a population of people who had cancer. So, with all of that said, these are my conclusions for this audience. One is realize sexual health is inherently human, that if it is something you miss or are having difficulty with, you deserve to have it addressed. The whole notion of at least you're alive is never appropriate, because we now know that not only is it important to acknowledge it, but there is actually help that can be made available. Sometimes the tincture of time is important, so compromises with your partner as to alternatives can be exceptionally helpful. This is not a conversation that most people are ready to have, because it's not a conversation that any of us thought we would need to have anyway. The three things I oftentimes will tell people to help motivate that conversation: what do you want right now? What do you wish for in the future? And what do you need? Okay, because all of those things can help your partner and you provide number four, which is clarity. What are your expectations of yourself as well as your partner? Because at the end of the day, everyone deserves the sex life they want. And that includes the young adult, the older patient, patients in relationships, patients without a partner, LGBTQ people, people with advanced or metastatic disease, and it includes the oncologist. So, with that, remember, cancer is a social disease, and the patient dealing with breast cancer and his or her partner are also needing that help. So, with that, I'll close, and I'm happy to answer any questions.
Oh,
Thank you very much.
that's wonderful. Thank you, Dr. Dizon. This has been very
Good.
informative. We do have a couple of questions. Um, one question that has come up, reads, when you say after cancer, do you actually mean after cancer treatment?
That's a really important question. So I adhere to the National Coalition for Cancer Survivors definition, which is after a cancer means an after a cancer diagnosis. Okay. So even while someone is on treatment, even if it's, just surgery or with radiation or chemotherapy or on endocrine therapy, the appropriate time to discuss sexual health issues is when that person wants to discuss it. I will never say it's not an appropriate time to discuss sexual health, because at the end of the day, the only person that that's going to impact is the person going through it.
There was a question that was emailed to me. I'll just read it to you.
Mm-hmm.
It reads, I know that it is advised to abstain from intercourse for 48 hours after chemotherapy and that condoms should be used afterward. What about kissing?
Yeah, so the whole question is, what are the concentrations of chemotherapy in body fluids? That's really the biggest issue. And the point of fact is, the data is exceptionally old, and a lot of our newer drugs we haven't checked. So I don't know what the concentration is of Taxol in the body fluids. So the rule of thumb is waiting 48 hours is appropriate. Has there ever been a case of chemotherapy side effects in the partner of someone who's had sex unprotected? I am not aware of that ever being reported. So the guidance you're getting is best guesses at most. Um, and I yield the same advice. If you're worried about a pregnancy, then that's where the condoms come in. If your interest is in sexuality, then I don't know how important the condoms are. But remember, if there's a chance you could be fertile, there is a chance you could get pregnant. So that's, I think, is the more important issue of condoms. As far as kissing goes, absolutely safe to kiss people. I would encourage intimacy during treatment. Um, and oftentimes, if you want, I think the lived experience is that oftentimes people just don't feel great during treatment or after, immediately after, to want to be very intimate. But intimacy for women is not the same thing as intimacy for male partners. So, really getting on that same page as to what you're looking for and what you want and need is really, really critical.
Okay, I have a follow-up question to the last.
Mhm.
It says, how can you differentiate between mental effects of the diagnosis compared to treatment effects, chemo, surgery, endocrine therapy?
I think they're all exceptionally tied together. That's the thing. So there are, let me answer it this way. So we've always been searching for a clearer delineation of what is age related, what is surgery related, what's medical therapy related, and we can't because oftentimes as you're going through your treatments for cancer, your body is aging. It's aging naturally, and now it's aging maybe a little bit more rapidly due to the therapies that we're giving you. And that makes the whole thing very complicated. So, in terms of how can you distinguish one of them, and the way I sometimes will um, you know, talk to folks is that what your cancer experience or what your sexual health was like before you were diagnosed with cancer can help really distinguish these things. A lot of folks walk into a new diagnosis of cancer already with had experiences where their sexual health was not the same as it was, say, 5 years before. A lot of people who had kids had a lack of intimacy because they didn't have time, had less frequency, again, because they were multitaskers, or were having issues with dryness and pain with penetration because they were already entering menopause. So I think, that big cue can let you know whether or not it's an acceleration of what was already happening or if it just happened and you can almost point to when it happened, which is what is the case. That is generally what happens post surgically and the loss of breast specific sensuality.
Okay, let me see. I don't, are there any more questions from our audience?
There, let's see. So there was a question. Oh no, you actually asked us.
Yeah.
Yeah,
I think I was looking at all of the questions that I forwarded to you from our audience when they sent them beforehand. I
yeah.
think you, yeah, I'm looking at them. I think you hit every one. Yeah, that's great. Um,
Yeah, I mean, I think the more important thing is just to know that, this is the experience of changes can be really isolating for so many people. And it's so private and so confidential that it is not uncommon for people to suffer very silently. I will also say the opposite that I've met a ton of people who have these experiences where their sexual milieu has changed and it doesn't bother them. The last thing I want to do is create an issue where they don't see one. Okay. The whole point of that is that we all have something called a schema sexually. That's just who we are. And there's no right or wrong about it. So it explains, the schema is basically informed by, your own prior sexual experiences, but also the culture you grew up in, the religion you had, the society you had, the friends. And it explains why something might be offensive to one person and not a big deal to the other when it comes to sexual, provocative material. that schema influences how someone is going to do and what's going to happen with them sexually afterwards. But the other thing I think is also even more important, there are multiple reasons why someone wants to have a sex life. And after cancer is not the time for me to insert my own judgments and values. There are people who need to be sexually active because of gratitude that their partner was there for them and they need to be there for their partner now. There is responsibility. There's this sense of duty, which I hear about. And then it's motivations by fear. But also, some women just need to feel this part of them, no matter what, no matter how much it hurts. But it's that important to them. Every single reason is valid. Okay. My goal is to create that experience or help you recreate that experience as pleasure, not as something expected or not as a duty.
I really appreciate that. I hear um, a lot of the women that I communicate with. This is definitely, a subject, a very, very touchy subject that it is
Yeah.
hard to know who to talk to. And actually, one of the questions that came up here is, so where should we start to seek help if we have these issues? An oncologist, a GP, a gynecologist? I think that's an excellent question.
Yeah.
Took me almost 5 years to figure that one out, but
Yeah. Yeah. So, what I would say is that most of the folks who see me, and it differs, come from their oncologists who I've networked with or who have heard me talk. A lot of them come from social workers and nurses because that's who really get to know their patients exceptionally well. And there's this sense of familiarity and comfort and trust that the supporting team of the oncologist may be the person more likely to provide you that ear, that sort of compassionate ear. And I think um, that's not an uncommon experience because when I see people in follow-up of breast cancer, oftentimes the one thing they want to hear is you're okay. So we talk about physical issues, and then at the end of the day, I can say, oh, look, I think you're doing fine, and I'll see you in 3 months. And we leave the room, and you have no opportunity to ask your questions. So my advice is ask the person who you most feel comfortable with about this. Now, if there's no one there, I think your oncologist would love to believe that you will tell me sort of if something's wrong and you need help. But what we know is that unless the door is open, um, issues of sexual health are not discussed. So it does take a very strong person. There are great online resources from Living Beyond Breast Cancer and the Young Survival Coalition, as well as American Cancer Society, where you can get some information about this in the privacy of your own home. There are books that were written around sexual health by, colleagues of mine like Ann Katz from Canada, Michael Critchman in Los Angeles, and these are sexual health after cancer specialists, which I think is also critical. And then, there should be resources in every single town across the United States where there is someone who can be compassionate and look at the issue from the lens of an oncologist or a cancer perspective. The work I do is very different from people who are sexual health specialists and have TV shows, right? Because the issues are very, very different. But there are resources online, and I think great people like Jillian bringing this kind of information to you can also be a start, so that you can actually hear this is exceptionally common.
mm, it's very validating to hear you, say this and give this a safe space to talk about the issues that we
Yeah.
have. We have a few more questions here. Let's see. Is vaginal dryness worse after tamoxifen?
Surprisingly, it shouldn't be worse after tamoxifen. The hot flashes tend to be something I hear about quite a bit, but the way tamoxifen works, it's selective, right? So it modulates the receptors on the breast differently than it does everywhere else in the body. So oftentimes the sexual health issues, including vaginal dryness, is not severe. Although I will say I do see the genitourinary symptoms of menopause in people taking tamoxifen, and I do hear about changes in sexual health from that. But say compared to the aromatase inhibitors, the sexual side effects are less severe because the aromatase inhibitors don't selectively block breast tissue estrogen receptors. It turns off the body's production of estrogen.
Mm. Okay, we have another question. It says, any suggestions about dealing with the lack of spontaneity because arousal, if anything, takes so long?
Yes, I have a great suggestion
Great
for
question.
that. So, one of the things that I think after treatment for cancer, everyone should understand is that your body's erogenous zones have changed. Like I said, most women have lost breast specific sensuality, and your breasts and your chest walls, almost 90% of people, it was the way they got in the mood. So there's an exercise that I will discuss with people called sensate focusing. And what that is it's a form of play, and it involves your partner, and it involves touch, and it doesn't involve talk, and it doesn't involve intercourse. But what it does help you and your partner do is to reconnect tactilely in a very safe way. So in stage one, you sit right, next to each other, quiet, dark, no distractions, which is difficult if you have kids, right? But you find that safe time. You can be clothed, you can be non-clothed, but you take turns touching each other on each other's bodies. And the only cues that your partner has is your expressions, okay? And you let yourself be felt and touched, and you touch in return, and you work your way up in terms of the intensity of the experience, and you allow yourself to have intercourse only at stage 4. So again, what that does is it resets intimacy, and it resets the sort of patterns that we all have of how we end up having sex, and it flips it so that play becomes an exercise, and play begets pleasure. And that's the goal.
Okay, we have another question. They're coming in. For those experiencing dryness, do you have any recommendations for tearing during intimacy? I assume that means during
Yeah.
sex.
Yeah, no, what's interesting is that, uh, pelvic exams are really important because it is quite frequent that I'll see two things. I'll see a huge inflammatory vaginal response, like vaginitis, that's not related to infections. And then I'll see little fissures in the skin because the skin is just, or the vaginal mucosa is just very dry. In both of the scenarios, the treatment may be a very low dose steroid cream to help control the inflammation and help rebuild or reduce it as well, and then allow healing of the fissuring and the tearing during intercourse. Because what happens is with the menopause, especially accelerated menopause, the mucosa just becomes so thin, like just like tissue paper thin, and that's what causes the fissuring. So the first things first, no intercourse to allow healing, but get a physical exam because it might be an indication to have some steroid cream.
Okay. And the last question here, I think you did address it, but I'm not sure it was specific for early stage. The question reads, what lubricant can you recommend for women during early stage breast cancer?
Yeah, so the lubricants that we recommend are the same regardless if you have early stage or metastatic. What I think is more important is, your preferences on what kind of lubricants you want to use. Water-based lubricants, I think, are great. If you're the type of person who wants to just enjoy things and not have to consider reapplying, then I think the silicone-based lubricants work well. Luvina, which I mentioned is parabens free as a moisturizer, can also be used as a lubricant, which is nice because it has dual purposes. Um, and I think the other important point about a lubricant is that you have to make sure to use it both on your partner as well as on yourself.
Okay. All right. Are there any more questions from our audience? No? Well, thank you very much, Dr. Dizon. This has been so info. I've been looking forward to this presentation since we scheduled it. I think you've shared a lot of details for um, women like myself to, feel more confident and empowered to make some decisions about our bodies and moving forward, so we can enjoy those very human experiences that we all enjoy. So thank you so much.
Oh, Jillian, thank you so much. I've been looking forward to meeting you finally. I'm sad it's not in person, but we will be working together again.
Yes, thank you so much.
Thank
And,
you, everybody, for
and for
joining.
the audience, I did. This is recorded, so I'll share this link with everyone who is who signed up to attend. So, all right.
Thank you very
Thank
much.
you so much. Have a good evening.
You too. Bye bye.